Hello, everyone. We're now going to be discussing the medications for neurological disorders. So here we are, phenobarb. This is an old barbiturate, been around since 1912. It's able to suppress seizures without causing generalized central nervous system depression. And you can see what it controls: tonic-clonic seizures, partial seizures, and also status epilepticus. And then we'll move on to Dilantin, which is the most common drug given in the United States for are anti-epileptic drugs. That's what AED is here. Very historic importance of Dilantin. It's the first drug that they came up with to suppress seizures without depressing any part of the central nervous system. So they use it for almost everything. Tonic-clonic seizures, partial seizures, not for absent seizures, though. I will talk about that in just a second. And the therapeutic range, again, it's another one like our aminophylline or bronchodilators, in 10 to 20 micrograms per cc. So there's our number again. And what's noted here, capacity of the liver to detox the drug can be taxing. So we have to pay a special attention to this level so that we don't hurt the liver. And then an absent seizure, I wanted to go over that for a minute because what does that mean? It's kind of like contradictory. And it is a brief sudden lapse in consciousness, more common in children than adults. They don't fall down or anything. It's almost like just a blank stare. They may look like the person is staring off into space for a few seconds. It's very, very hard to diagnose because are they just thinking? Are they just looking at something specific? So extremely hard to diagnose. So we don't use Dilantin for that one. We use them for almost every other one. Adverse effects, a nystagmus, which is the eye twirling around in your head, mental confusion, gingival hyperplasia is a big one, and that's why it's bolded here, where they have an overgrowth of gums. A lot of times if you're walking around the mall and you see these kids in wheelchairs that have cerebral palsy, they have that because they have seizure disorders. Let's see. Osteoporosis, so softening of the bones. It can be very toxic to veins, so we have to be especially careful when we're in the hospital and giving this. Ataxia is a gait that's not steady, and it can also cause some sedation, but not like a central nervous system depressant. So how does it work? How does our Dilantin or phenytoin work? It causes selective inhibition of sodium channels, basically. It inhibits the sodium channel, slows the recovery of sodium channels from inactive state back to an active state. Entry of sodium into the neurons, when this happens, the inactive state back to the active state, entry of sodium into the neurons is inhibited or slowed down. The action potentials are suppressed. Blockage of sodium entry is limited to neurons that are hyperactive. So again, selective inhibition of sodium channels to the point where blockage of sodium entry is limited to the neurons that are hyperactive. Result is the drug suppresses the activity of seizure operating neurons while leaving healthy neurons unaffected. Another medication for seizures is Cerebrix or fosphenytoin, and you can kind of see that it's almost the same family as Dilantin. It was developed in hopes to not have as many side effects as Dilantin. Very, very chemically, they're very similar. Water soluble, it does not burn the vein like Dilantin. And then we got valproic acid or Depakote, very broad spectrum anti-epileptic drug for generalized seizures, myoclonic, tonic-clonic, which are the, tonic tone is very stiff, and clonic is when it's not stiff and it's contracting in and out. Are absent seizures and the ones without tone. Toxic effects for Depakote is hepatotoxicity. Again, another one that's going to hurt the liver. I think they all do, especially in children under 2 who are taking other anti-epileptic drugs, and it can also cause pancreatitis. And we have Tegretol, second most commonly prescribed anti-epileptic drug in the United States, used for partial and tonic-clonic, much better tolerated than Dilantin, and it's often preferred. So once again, we're going to go with the lowest one to cause toxicity first. They will probably start with Tegretol, and then if the person can't be maintained on that, we will move on to either fosphenytoin or phenytoin. Adverse effects for Tegretol are the blood. It affects the blood, whereas Dilantin more affects the liver. Leukopenia, which is lack of white cells, anemia, lack of red cells, and thrombocytopenia, lack of platelets. So basically, it goes without saying that we would need to obtain a CBC or a complete blood count at the baseline and periodically check on this drug. Medications for seizures and very good information to know. I've compiled a couple things here for you. Dilantin, carbamazepine, Tegretol, and phenobarb induce the synthesis of hepatic drug metabolizing enzymes. And all of that big word means is it can, it helps increase our liver drug metabolizing enzymes and can accelerate inactivation of other drugs, because we know a lot of drugs in doing this inactivates it, induces these enzymes that are going to inactivate it. We know a lot of drugs are metabolized in the liver. Oral contraceptives, warfarin or Coumadin, which is a major blood thinner. So it's good to know, so we can tell people who are on these that, you may have trouble with birth control, or if they are on blood thinners. For all anti-epileptic drugs, we need to monitor the plasma drug levels for adjusting dosages, monitoring adherence. That means, are they taking them? We want them in that 10 to 20 microgram range. Determining the cause of the last seizure and identifying the cause of toxicity, especially if patients are taking more than one drug. Withdrawals of anti-epileptic drugs must be done extremely gradually, or the patient's going to go into a full-blown seizure, because abrupt withdrawal can trigger that status epilepticus, which is not compatible with life. It's a seizure that they cannot stop, lasts a very long time. And all anti-epileptic drugs may pose a risk for suicidal thoughts and behaviors. We know that, so that has to be watched extremely carefully. Most anti-epileptic drugs cause central nervous system depression, which can be increased by using another one, or by using concurrent use of other CNS depressants. So if they're on these, we know it's going to quiet the brain a little bit anyway. They shouldn't be on alcohol or antihistamines. Antihistamines can gork people out and they don't even know it. Opioids and other anti-epileptic drugs. And then another important thing to know with anti-epileptic drugs is non-adherence counts for nearly half of all treatment failures. And so what that means is they forget to take the drug, or they're not taking the prescribed amount of drug when they're supposed to. So we have to promote adherence. It's a priority with these drugs. Otherwise, they're going to lose brain cells. We know during a seizure, the uptake of our oxygen is not good. It's not what it's supposed to be. So to treat status epilepticus, and again, this is going to be a seizure that just continually goes on and they have a very hard time stopping it. You can see we're going to give Ativan IV to sedate them, Dilantin IV because it's the powerhouse of our AEDs, together with Cerebrix, which is the sister to Dilantin, and phenobarb. Adverse effect could be sedation, but tolerance to this effect usually develops with continued therapy. Our pediatric patients to phenobarb, sometimes they have an adverse reaction, meaning the opposite. Instead of becoming quiet and sedated, they become irritable, hyperactive, with sleep disorders and cognitive abnormalities. So again, you're going to get that history from the parents, and then they can try something else. Okay, so that's for our seizures. Moving right along, we're going to go into our drug therapy for Alzheimer's disease, and we covered that. So you know what Alzheimer's disease is. The cholinesterase inhibitors, what are those? They prevent the breakdown of acetylcholine, or ACH. We know that in Alzheimer's disease, we have a deficiency of acetylcholine. So we need a drug to prevent it from breaking it down. Formation of neuritic plaques in the brain, because that's Alzheimer's, because disruption of nerve impulse transmission, death of neurons due to loss of acetylcholine. So we need, knowing that with Alzheimer's, we need a medication to prevent the breakdown of acetylcholine by acetylcholinesterase, thereby increasing the availability of acetylcholine at those cholinergic synapses. We need acetylcholine because it's one of the major communicators in the brain. So we give them cholinesterase inhibitors that will prevent the breakdown of acetylcholine. Indicated for mild to moderate Alzheimer's disease, it helps to slow the progression of the disease. There's really no cure for Alzheimer's, but we can try to manage it. So our cholinesterase inhibitors, what do those look like? We've got our Aricept, Exelon, and Razidine, which you can see are all used for mild to moderate Alzheimer's. These three drugs are recommended by our Federal Drug Administration for Alzheimer's disease. They've seen improvement with cognition, that's how we think, behavior and function, and slightly delayed disease progression. There are some adverse side effects because we're calling them, anticholinergic. There's cholinergic side effects such as bradycardia, hypotension, because they overstimulate the parasympathetic nervous system. They can have GI upset, headache, bronchoconstriction, and liver injury. So you can kind of see liver injury is big, bronchoconstriction, bradycardia, they're all big. So we have to watch them very carefully when we first give these drugs. But they are very effective. Memantine is another drug that we give. It's an older drug than the cholinesterase inhibitors. It modulates the effects of glutamate at the NMDA receptors. And the NMDA receptor, it's a transmembrane protein with a central channel that regulates calcium entry into the neurons. Binding of glutamate to the receptor promotes calcium influx. Under healthy conditions and action potential, just the way the communication is working amongst the neurons, releases a burst of glutamate into the synaptic space. Glutamate then binds with the NMDA receptor, displaces magnesium from the receptor channel, and thereby permits calcium entry. Glutamate then quickly disassociates from the receptor, permitting magnesium to reblock the channel and thereby prevents further calcium influx. The brief period of calcium entry constitutes a signal in the learning and memory. Under pathologic conditions, there is a slow but steady leakage of glutamate from the presynaptic neuron and from surrounding glia, which are the glial cells of the brain cells, Two, as a result of the channel in the NMDA receptor, it's open, thereby allowing excessive influx of calcium. High intracellular calcium has two effects. It can impair learning and memory because the noise created by excessive calcium overpowers the signal created when calcium enters in response to glutamate released by a nerve impulse. And two, we have neurodegeneration because too much intracellular calcium is toxic. So it's going to modulate the effects of glutamate at these receptors, which are believed to play a critical role in learning and memory. First drug in this new class of, and again, NMDA, what is that? It's N-methyl D-aspartate, indicated for moderate to severe, so a little bit stronger memantine is than the cholinesterase inhibitors. It's better tolerated, so it doesn't have those strong side effects, but it does have adverse effects, such as dizziness, headaches, confusion, and constipation. Other treatments for Alzheimer's disease: vitamin E, NSAIDs, anything that hurts the body like this, they say is inflammatory. Estrogen, ginkgo biloba, simply because, and we get that from the health stores, memory and concentration enhancer, an anti-vertigo agent, and we can see that a lot of this stuff can cause dizziness. And then drugs for neuropsychiatric symptoms, if they becomes very agitated or aggressive, have delusions or hallucinations. Okay, I'm going to stop there and we'll pick up with another segment to talk about our stroke victims for our neurological module.